In my last pair of videos, I looked at the problems associated with the most popular form of therapy, cognitive behavioral therapy. Namely, in brief, how researchers present CBT as being the most empirically based form of therapy, despite the studies that support it often being weak or low quality. How, when the cognitive components of CBT are studied separately, the results undermine the idea that thoughts must be challenged in therapy. And how, by being fixed on the problems in the here and now, the therapist, when adhering to CBT, may ignore a client's broader underlying difficulties. Moving on, however, I wanted to look in some depth at a text from a psychoanalytic perspective, one that offers useful comparisons to the idea that the therapist should challenge, or question, if you will, the client's thoughts and beliefs. To that end, I will read at some length from the book Gaslighting, the Double Whammy, Interrogation, and Other Methods of Covert Control in Psychotherapy and Analysis by psychiatrist Theo L. Dorpat and published in 1996. From the Introduction and Overview. My overall aim in this book is to write about a widespread and serious malady in the way many clinicians conduct psychotherapy. I believe this unrecognized disorder has been present throughout this century and that it is widely prevalent in this country and elsewhere. There are two chief symptoms or manifestations of this disorder, and they are: 1. The clinician frequently uses methods of indoctrination for the purpose of controlling and directing the patient, and 2. The clinician is unaware because of ignorance and/or denial of the fact that he or she uses such indoctrination methods and their short-term and long-term effects on patients. More often than not, patients are also not aware of the use of these methods or of their effects on themselves. This can be compared, as I have covered elsewhere, to the possibility of the therapist or client-patient themselves believing a harmful or otherwise ineffective treatment is effective. These points are from Iatrogenic Symptoms in Psychotherapy and Why Ineffective Psychotherapies Appear to Work. As Dorpat continues, the sexual seduction and overt abuse of patients by some practitioners is only the visible tip of the iceberg of the widely prevalent abuse of power by mental health professionals. The more gross kinds of patient abuse, such as financial or overtly sexual exploitation, are expressly forbidden by rules and bylaws in medical, psychotherapy, and psychoanalytic organizations. Both in Freud's time and in our own time, however, there are few laws or regulations set down to discourage the more subtle and covert forms of interpersonal control, exploitation, and abuse. The use of more covert methods of interpersonal control and other indoctrination methods is not even considered abnormal or exploitative by many clinicians. Though, unlike some other types of psychotherapy, psychoanalysis specifically prescribes, that is, forbids, the use of directive and controlling methods and the varied forms of indoctrination. Their use is nevertheless widespread in psychoanalytic treatment. For the purposes of this book, I use the term psychoanalytic treatment to refer both to psychoanalytic psychotherapy and psychoanalysis. Unlike some other types of therapy, these are Dorpat's words, not mine. However, looking back at CBT, it seems more than fair to ask how this specific system of therapy is not explicitly directive and indeed controlling, as Dorpat is discussing here. Again, what is CBT? This is from the article Cognitive Behavioral Therapies, Achievements and Challenges. The CBT model proposes that psychopathology is the product of faulty information processing that manifests itself in distorted and dysfunctional thinking, which directly leads to negative emotions and maladaptive behaviors. In the relationship between the CBT therapist and client, who is the one providing the labels, faulty, distorted, and dysfunctional, in relation to the client's information processing and thinking? The therapist. To whose supposedly healthy processing and thinking will the client then be pushed to conform? The therapist. This seems perfectly set up for the kind of control and manipulation Dorpat addresses here. And as Dorpat continues, this is obviously not the case with CBT alone. From Freud on to the present time, psychoanalytic treatment has often been compromised by a set of controlling attitudes and indoctrination methods contrary to its avowed values and technical precepts. My studies suggest there exists among many, perhaps most, practitioners a complex of disavowed aims, strategies, and actions carried out for the most part unconsciously in the interests of directing and dominating their patients. For the purposes of this study, I have coined the term covert methods of interpersonal control to refer to a subclass of indoctrination methods. The tactics and methods of covert interpersonal control include different types of projective identification wherein individuals, through various kinds of interpersonal manipulation, exert control over the cognitions, affects, and overt behaviors of others. Again, while Dorpat is discussing psychoanalysis, this certainly appears to fall directly in line with the explicit aims of CBT. Where do these indoctrination methods come from, and where do mental health professionals learn them? In part, they learn them in their professional training programs, in their psychiatric residencies, and in psychoanalytic institutions, mainly through identifying with the practitioners who educate, supervise, and treat them. Today, the trend toward the use of indoctrination methods has been amplified by the markedly diminished time in psychiatric training specifically set aside for learning psychoanalytic psychotherapy. The increasing emphasis placed on the use of manipulative, short-term, and directive methods in the training institutions for mental health professionals, psychiatry, psychology, nursing, social work has contributed toward the increased employment of indoctrination methods among mental health practitioners. My first clinical studies on the use of covert methods of interpersonal control in psychotherapy and psychoanalysis were concerned with the effects of the clinician's use of questioning on the patient and the treatment process. My clinical investigation led me to conclude that questioning was frequently prompted by unconscious countertransference problems and was often used in behalf of directing and controlling patients. More often than not, questioning has a stultifying and inhibitive effect on the treatment process. I have been supervising and teaching psychoanalytic psychotherapy treatment for over 35 years, and in each year in my individual and group supervision sessions, I hear approximately 100 patients in some kind of psychotherapy or psychoanalysis. I am completely confident of my opinion that the use of covert methods of interpersonal control and other indoctrination methods is 1. Widely prevalent among clinicians, and 2. Most practitioners, and especially those who use such approaches, are unaware of their significance or their effects. In approximately 100 cases I hear about each year, I estimate that in 40% there is the mild and occasional use of indoctrination methods, and in another 40% there is a moderate employment of such methods. In a third group of around 10 to 20%, there is a very serious and destructive use of such methods. Here I would reiterate information from other sources that address therapy in a broader sense. Numerous studies have indicated that about 10% of clients become worse following psychotherapy. And this is from Iatrogenic Symptoms in Psychotherapy and is reiterated in Why Ineffective Psychotherapies Appear to Work, with an additional citation also included. If 10 to 20% of psychotherapists use such serious and destructive methods, then it is no wonder that 10% of clients become worse following therapy. Continuing with Dorpat from Chapter 1 of his book, What are Types of Covert Methods of Interpersonal Control in the Therapeutic Situation? Gaslighting. Gaslighting is a type of projective identification in which an individual or group of individuals attempt to influence the mental functioning of a second individual by causing the latter to doubt the validity of his or her arguments, perceptions, and/or reality testing in order that the victim will more readily submit his will and person to the victimizer. Questioning. Questioning, especially if it is repetitive and directive, is a method by which clinicians can and often do gain control over their patients' mental functions and communications. As I indicated in previous publications, questioning tends to promote in the patient a mode of thinking and communication opposed to the methods and goals of psychoanalysis. While these supposedly go against the methods and goals of psychoanalysis, how do they not fall directly in line with the aims or methods of CBT? Defensive interpretation. There is an excessive need on the part of some psychotherapists to make defense interpretations. Such zealous assaults by the therapist on their patients' defenses often constitute the enactment of hidden agendas for the control and domination of the patient. In my supervisory experience, I have found that the excessive and inappropriate use of interpretations or unconscious defense is often done for purposes of controlling the patient. In CBT, what might happen if a client or patient defends their supposedly faulty, distorted, or dysfunctional information processing or thinking? Confrontation. The technique of confrontation is made to order for serving purposes of controlling, directing, humiliating, or dominating. Though some of the older texts on psychoanalytic technique describe confrontations as an acceptable and useful technique, my own experience in doing, teaching, and supervising psychoanalytic treatment has witnessed few occasions in which confrontation have facilitated the therapeutic process. Often confrontations are anti-therapeutic projective identifications in which therapists consciously, or more often unconsciously, attempt to intimidate or at least influence and control patients by engendering painful emotions such as fear, guilt, shame, or anxiety. How is directly taking on a client or patient's thought processing, and at the very start, not a clear case of confrontation? Taking on a client or patient's thought process is, if I have not made it clear enough, the specific aim of CBT. And while Dorpat is looking at these problems as they arise specifically in a more traditional form of therapy or psychoanalysis, it seems obvious that CBT, the most popular form of therapy today, is implicated here as well. At the very least, CBT appears, by its very nature, to be controlling and manipulative. As Dorpat continues in the concluding comments of the final chapter, chapter 11. I urge changes in psychoanalytic and psychotherapeutic technique in the direction of a more egalitarian relationship, and one which limits the potential for the therapist's abuse of his or her powers. Psychoanalysis needs more emphasis, such as is contained in Weiss's pro-plan approach, on helping patients achieve a greater degree of autonomy. As patients become more skillful and courageous in participating in the treatment process, they should be entrusted with greater responsibility and freedom for making their own interpretations and reconstructions, as well as devising operative metaphors and narratives. We need an ideal for psychoanalytic treatment which emphasizes a more fully democratic ambiance and in which patient and therapist from the beginning understand the need for both to take responsibility for the discourse in order to facilitate the patient's insight and recovery. Of course, notice how Dorpat leaves the patient or client with the principal first responsibility to participate in the therapist's treatment process. And only after that participation process should they be entrusted with greater responsibility. And with the serious implications of all the issues Dorpat addresses here in his book, while he is already on the one hand trying to blame other types of therapists, he still emphasizes the following in Chapter 1. Though I shall in this book frequently discuss the damaging psychic effects of covert methods of interpersonal control, I believe we should exercise some restraint in criticizing mental health professionals and other persons who use these directive methods. Most often, they do not consciously intend to injure others, and most often because of the group denial, they are unaware of what they are doing and of the psychic effects of what they are doing. And although I only noted one comment from the author on the topic, it bears repeating, and I am emphasizing this specifically for those who are only capable of responding to this one kind of subject matter. Keep in mind that sexual coercion and control in therapy is also a major topic of Dorpat's book in his discussion of covert methods of interpersonal control. In other words, the bottom line for Dorpat is, although mental health professionals are capable of serious controlling and manipulative behavior, and of otherwise harming their patients' clients in deeply impactful ways through such controlling and manipulative behavior, you should exercise grave restraint in criticizing them, or him, mind you. because these professionals do not really mean to be so harmful. Or at least, not all the professionals who cause harm mean to do so. And I do think it is more than appropriate to use the pronoun you here, even though the author uses we, because he himself is indeed among the professionals he is addressing. But as a psychoanalytic psychotherapist, he can only go so far to criticize his own kind. And next, I think it is time to take a step back from treatment to look at the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, the principal handbook used by mental health professionals to diagnose mental disorders. I hope to see you there.